and thank you for joining us. I'm Judy. I'm the Executive Director of F.E.A.S.T. Just a few small housekeeping rules. We'd appreciate it if you would keep yourselves muted and keep your cameras off for the duration of the presentation. When the presentation is over, there will be a chance to ask questions. And we're going to do what we did last month, which is to allow people to turn their cameras on and to turn their microphone on to ask questions. So if you have a question, just jot it down during the presentation, and afterwards just raise your Zoom hand and I will call on you, and then you can turn your camera and your mic on and ask your question. And I just ask if you can just turn it off when you're finished. And I'm going to get started on introducing our speakers. Today, I'm going to give the abridged version of our speaker's bio since we have two presenters, and I don't want to take up too much time. Dr. Jocelyn Lebow is a child and adolescent psychologist at the Mayo Clinic. Her clinical role is embedded in primary care, where she provides psychological services, including assessment and interventions to families and young patients who have presented to their primary care provider with a broad range of presenting concerns, including mood, anxiety, and eating disorders. She is particularly interested in working to make FBT, family-based treatment, and other evidence-based assessments and intervention strategies more accessible for patients. Dr. Angela Mattke is a pediatrician in the Division of Community Pediatrics and Adolescent Medicine at Mayo Clinic Children's Center in Rochester, Minnesota. She is the host of the popular Facebook Live and podcast series, #AskTheMayoMom. I love that name, by the way, an interactive social media show that discusses pediatric health topics. She has been treating teens with eating disorders at Mayo Clinic using family-based treatment for primary care for the past several years. Thank you both so much for joining us today and for your valuable work in the field. I'll let you get started now.
Thanks so much for that great introduction. And this is always the scariest part. Let me try to share my screen. All right. Does that look good? And can you give me a thumbs up if that looks right? Okay. I'm always worried it'll be like my Jimmy John's order or something like that on the screen. Okay, so we are so excited to be here. Angie and I were just talking right before we started about how much we love F.E.A.S.T, how valuable your organization is, and we're just excited to be able to be here. Really, today we want to talk about, I think, something that's been a little underexplored in the eating disorder literature. So I'm a psychologist. I do research in the field. I do clinical work in the field. You know, we talk about it's important to have medical partnership. Everybody knows that. Who's had a child with an eating disorder, who's familiar with it. These are psychological disorders, but they're medical disorders. But I don't know that we've talked enough or thought enough about how to strategically leverage the primary care provider to get the most out of your care team that you can. You know, I think that we all have. Oh, and I should back up. As a disclaimer, it should be very clear, both Angie and I are like embarrassingly American. We are so American. And so when I talk about this to international audiences, our language we're just steeped in the American health system. So when I say primary care providers, I think this is comparable to general practitioners in Australia or Canada, or, you know, it's really the family doctor, nurse practitioner, or physician's assistant who's located in your community, who you see, you know, when your kid is born, for standard visits all the way up until they're 18. At least that's how it works in America. So again, we're going to be using the language primary care provider, but that's really what we mean. And so really we want to talk about today is how can we use them to their full potential? What you as parents and caregivers can advocate for, how you can get the most out of these visits, especially if you have a provider who's less familiar with eating disorders. And then, you know, unfortunately, we do have to talk about what do you do if you have a provider who's not just neutral and not just doesn't know very much, but is actually unhelpful. You know, we've all heard the stories. Some of us have had the experience. As a psychologist, I have had my work made immensely easier by being able to partner with providers like Angie. But then there are pediatric family medicine providers who can be unhelpful, right? And so really, how do you kind of talk with those providers and advocate for your child and to make sure that they get the care that they need? So backing it up again, why primary care? Why is it such an important piece? I have found, as Judy said, I work now embedded in primary care. That wasn't where I started. I started in specialty practice, kind of very removed from these offices. And when I moved here, when I started working in primary care, I was shocked by this wealth of, I guess, resources is the wrong word because they have no resources. Primary care gets no money and no time and no anything. But what they do have, you have this practice of providers who in some cases have worked with this child since they were literally born, since they were literally, a week out of the hospital. For family medicine, in America, you sometimes have a provider who has worked with the family for generations. So not only do they know your kid, they might know your entire family system. They can help you make sense of the messaging that you're getting from your specialist provider, I think more than many other medical professionals. They can use what they know about your whole child, right? Not just this one very specialized piece of them, to really help you keep your kids safe and make sure they're getting better from their eating disorder. They can help with continuity of care. So, we get a lot of patients at Mayo who have seen GI and they've seen endo and they've seen OB-GYN, they've seen all these specialists, and everybody, again, is looking at this piece of the child. Eating disorders, as we know, affect all those things and can be influenced by all those sort of systems. And the pediatrician, the pediatric provider, or the family med provider can really pull that together. We also know that you can get into them a lot easier than you can with specialty care. We don't have enough providers of good eating disorder care out there, not even close. We didn't before the pandemic, and since the pandemic, it's been even worse. But most people have access to a primary care provider. So if you're lucky enough to have a good one, or if you're able to kind of work with them to level up their experience, you can really help get in there early, which we know is important for outcomes for eating disorders. You can help reduce some of the ambiguity when you're not sure what to do with all the messages you're getting. Maybe you have a specialty provider telling you this is an eating disorder. Maybe you have a GI provider telling you maybe it's something else. They can help you kind of mesh this all together and make a cohesive message out of it. They can help you diffuse attention. They can repeat and reiterate the importance of this to family members who are less on board. They can echo this to your child coming from a different perspective, and that can be very helpful. And they can provide you backup, because I don't have to say this to this group. Having a child with an eating disorder is one of the most difficult things a parent has to go through. You need every single person on your team, and every single person on your team providing you support and telling you that you're doing the right thing, reinforcing your messaging and helping you get your kid better. F.E.A.S.T is such an important organization because eating disorders are so isolating. And so again, the more people that you can get on your team in your village, helping you and your child, the better. So what can a primary care provider do for you? And the literature is, there are good articles out there about, clinical guidelines and things that primary care providers need to know about eating disorders, but they are a little bit limited. The literature talks about identification and diagnosis for the primary care provider, how to assess for hospitalization and stabilization, this is crucial, how to medically manage an eating disorder, and Angie's going to talk a little bit about what these things look in detail later, and how to refer to and support specialists. So that is, again, when your provider is looking at the literature, that's what's out there and is fairly well documented. There's limited data on your primary care provider actually helping you with intervention. This is something that we're piloting at Mayo for sort of lower severity restrictive eating disorders with something called family-based treatment for primary care. There's some evidence that primary care providers can support guided self-help for bulimia. There's case reports of really they're providing intervention for other cases, but this has been pretty unexplored in the literature. So again, it's not unusual for providers to not think of themselves as having this role. And so again, as a caregiver, this may be something that you have to kind of talk with them. This is what FBT is. This is the type of treatment this is what CBT is. This is what we're doing. Can you help me in this way? And again, Angie's going to talk a little bit more about how to ask for those things specifically. In terms of what they think they know, there's been a lot of surveys out there of primary care providers and their attitudes and their knowledge about eating disorders. These published surveys suggest that most of them do feel that assessing and treating eating disorders is their role. Again, we treat eating disorders in specialty care most of the time, but the overwhelming majority of primary care providers recognize they see these patients, they see them often, and it's their job to help you as a parent assess and catch them. However, 68%, so the majority, only screen for eating disorders when it's the presenting problem. So this is problematic. We know we miss a ton of eating disorder cases until the illnesses have progressed extremely far along. As caregivers, as parents, I think what this says to me is, okay, most primary care providers want to do this, most are willing to do this, but you got to ask for it. You got to say, I'm concerned about my kids eating. If you go to your well child and they don't say anything about a drop in BMI, you have to say, I am concerned about eating. Should I make another appointment? Should I follow up? This is something that I'm worried about. And then largely because there is not that much out there for how they can do it, the less than a quarter of them feel comfortable treating eating disorders. So this is something where, again, I think as a caregiver, as a parent, you have to be a little more proactive, because it's going to be something that they're not going to offer if they're not comfortable. With regards to what they learn in their training, most residents come out of at least American-based medical schools wishing they had more training in eating disorders. So again, I think it's okay to ask, do you want some more resources? We have a section at the end where we talk about some of the good basic overview articles for pediatricians and family med providers to look at. But again, I think that's something you should not assume was just part of their care, their training. We actually asked our practice a long time ago. We did a needs assessment. What do you need to do better with catching eating disorders in kids? We surveyed our practice. We had 60 responses, and then we did an interview actually to get do a deeper dive, and about 16 replied. And we found that confidence was low, right? So on a scale of 1 to 10, on these top rows, where 10 is the most confident, managing eating disorders, evaluating eating disorders, diagnosing eating disorders, not that confident. But, and I think this is really important, how interested would you be in learning new tools or strategies? There was a lot of interest. And this, I think, matters too, because I think sometimes primary care providers get bad raps about not being interested. I think people sometimes think because they don't have this background or knowledge or confidence that they don't care, or that they don't recognize this as a priority. And sometimes that's true. But I think what overwhelmingly these surveys tell us again and again is they recognize this as a problem. They want to do better, but they don't always have the tools. When we talked to our practice about what was getting in the way, time is the big one. And so this will not surprise anybody. Our healthcare system, and this was back in 2017, so this was pre-pandemic. I think if we ask them now, they'd probably just start crying and not even answer the question, because there's just so many more barriers right now for the healthcare system. But really, primary care gets very little resources. They see patients for everything. They are screening for multiple things. They have to, and in at least in Minnesota, there are things that they're mandated to screen for, and they have to screen for safety, for health exposure, for screen time, for tobacco. They have to do abuse assessments. They have to look at your kid's weird rash. They have to do all this stuff in their session. And so again, making the decision, do I go deep into the eating versus do I try to convince this family about an HPV vaccination, like this provider said? It's a hard assessment for providers. So again, I think coming into it with an awareness of these challenges that are real. I think, again, this is something that I've learned in my time at primary care. People don't go into primary care because they want to be like millionaires and like famous. And these are very, very good people who want to help your kid and who just are chronically under-resourced in how to do it, just with time, with energy, with money. And so meeting them halfway and assuming that their intentions are good, I think is really important. Again, to underscore this, we think about, right, the primary care patient coming in, and it's this 14-year-old with weight loss. There's a 45-minute session. Mom's there for, to give collateral information. Like, how do they miss it, right? How can these providers miss it? Because they do. They miss it all the time. what I think we need to remember is, in reality, typically, and again, I think this is less the case for obviously families who are here in F.E.A.S.T who are informed, but a lot of the time, actually what it looks like is it's a 14-year-old, she's coming in and the presenting problem is rash, she's lost a couple pounds, but don't worry about it. Her stepdad's in the car if you need to ask him questions, but he doesn't really know how she's eating. It's a 15-minute appointment. That's the add-on at the end of the day. It wasn't even on the calendar. And oh, her brother's here. Can he get his vaccination, his immunizations for camp too? The primary care provider is scrambling. And again, their head isn't even in the right spot. It gets lost. So again, as a parent, as a guardian, going in with that understanding that this is what these appointments are, that if your provider feels like they're rushing, it's because they're rushed, and really trying to, I guess, have some patience with that, and again, focus it when you can, give them a roadmap when you can, instead of asking what should intervention look like, what should they be doing better, really I think we need to start asking what can intervention look like, and this is an important reminder for us in specialty care as well. Yeah. When we talked with these providers, so shifting gears a little, so the second thing that came up, in addition to we don't have any time, we are exhausted, there is, and again, I don't think I have to tell this group this, there are pervasive myths about eating disorders that primary care providers are just as susceptible to, if not more so, than anyone else out there. You guys know how poorly understood eating disorders are when you haven't lived it. And so, a lot of these myths are ones that in our practice, we're kind of counteracting every single day. Things that you want to be aware of that your primary care provider might not understand, might need some gentle re-education around, again, with kindness. I think there's a lot of providers who think eating disorder patients present looking one specific way. We know that this is still so pervasive, this idea that eating disorder patients look like a made-for-TV movie star, right? This has, that they're a cisgender, white, female identifying, high SES patient. We also know that primary care providers get a lot of education on obesity prevention. And so when they see a patient whose BMI is in the higher weight range, it's not as intuitive for them to think that this could be a restrictive eating disorder. When they see a patient in a higher BMI who loses some weight, it takes longer for those patients to be identified. So this may be something that you have to be a little more assertive about, that, yeah, no, I know that, her BMI is still above the 50th percentile, but she has lost this much weight. She's eating this way. This is a problem. A second myth that we run into a lot is either, it's kind of one or the other, eating disorder treatment is so complex, I can't possibly touch it or have a role or have any part on the team, which we know is false. We need these medical providers. Or eating disorder treatment can be done by anybody, can be done by any psychologist. They're in therapy, so it's fine. Uh-oh, sorry. Is that back now? Okay. She's in individual treatment for her depression. That's probably just as good. Again, I don't have to tell you guys, bad treatment for eating disorders is not necessarily better than no treatment for eating disorders. These patients do need specific interventions. And similarly to that treatment can wait, or this is probably just a phase, or, this is just a thing that teenagers do. Primary care providers, one of their main jobs, and I say this as like a mother of a 4-year-old, one of their main jobs is to calm parents down, is to have parents who present to their office freaking out about like a million different, very tiny things. Their job is to calm us down, to help us understand that, our child is going to be fine, is not going to grow up to be like a serial killer because they, like, I don't even know, like, I can't even tell you the things I've asked my pediatrician, right? So again, their inclination, that is really a bulk of what they do. In eating disorder work, that's not appropriate, right? In eating disorder work, it really is, no, this is a crisis. No, you do need to take this seriously. No, your child may be telling you it's no big deal, but it is. So again, this is a big shift for them. And I think I think this has been a big change in our practice as we've started educating providers on how serious eating disorders can be, is that usual approach is actually the opposite of what we want. We run into this one a lot. We run into, so when you have a child presenting with amenorrhea, but they're an athlete, she's an athlete. She's a really good runner. She's an elite athlete. A lot of providers sort of hand wave it away or start an oral contraceptive to get her period back, which, as has been pretty well established in the literature, doesn't actually help with bone density, which we're concerned about, right? People talk about RED-S, relative energy deficiency syndrome, or the female athlete triad, as if there's something different or as if there's something normal. Again, I think it takes some education that just because you've got somebody who is an elite athlete doesn't mean that amenorrhea is normal, doesn't mean that it's healthy. Same thing with having a low heart rate. We've gotten in some conversations with some of our cardiologists at our practice where resting heart rate is extremely low, is very concerning. And people are saying, well, could it be just because she's a runner? And again, we know that this is a marker of malnutrition. This is very, very dangerous. And so again, this is something that if this comes up for your child and they happen to be an athlete, this is something you may have to advocate for. And again, we have some resources at the end that can help you do that. We have this one. This one causes a lot of confusion actually in our practice. If a patient shows up who's lost a lot of weight, but who doesn't express body image issues, who says, no, I didn't mean to lose it, I'll totally gain, and then they don't, and then they don't, and then they don't. Again, we know first of all, there are diagnoses that you do not have to have body image issues, right? If you look at ARFID, if you look at some of those diagnoses, it's not as crucial, but we also know that there are patients who just don't endorse it. We also, anorexia can be diagnosed both with expressed body image issues or just a persistent refusal to gain weight when it's been pointed out, right? Even if they're not purposely losing weight. Helping providers with that, I think, is important. The same thing happens, it tends to get a little murky when we have patients who we talk about backing into an eating disorder, which I think is, honestly, I think it's less the exception and more sort of the rule. These are these patients whose weight loss began because of they got started on a medication. They had some depression, they had some anxiety, they had some chronic pain. They started losing weight legitimately, not purposefully, with no body image concerns. And then over time, it kind of morphed into this anorexic mindset. We see this all the time. We know from the Minnesota Starvation Study that this is a very common etiology for eating disorders. But there are some providers who get caught up in this, that if it didn't start, again, in that sort of made for TV movie way, that it can't be an eating disorder. And similarly, they get distracted then often by these comorbidities, mood, anxiety, pain, and they start trying to fix it. Again, primary care providers want to help. They want to help your kid, so they'll put in an SSRI. They'll start kind of really tackling the trauma, the stomach aches, the nausea. Like I said, they'll put an oral contraceptive on there for the missed period. They're treating these symptoms of the malnutrition or of the starvation and missing kind of the underlying cause. Again, as a parent, this is something where you can really advocate, right? And again, we have some resources at the end that you can use to kind of support your arguments, but it doesn't matter how you got there. It doesn't matter if your child legitimately has premorbid depression, anxiety. We have to treat the eating disorder first before these medications and therapies will even be effective. And reinforcing that to your provider, I think, can be very helpful. Okay, I'm going to turn it over to Angie and try to drive the slides like you want me to.
Sounds good. So really excited to be here talking with you today. I'm sorry, I'm feeling a little under the weather, so my voice sounds like I'm a smoker or something else is going on, but hopefully I can keep it up so you can hear me throughout the rest of it. Like Dr. Lebow has said, we want to help your child in any way possible, but the realities of primary care do not necessarily support having a lot of time, a lot of resources to really do it. And so what I want to spend time talking about is what should that visit look like, especially when you bring up those first concerns, and how can you continue to part with them while you're waiting to get into an eating disorder treatment program, because everywhere there's wait, everywhere there's not enough providers. We know there's some states that don't even have eating disorder providers and places around the world. So how can we gently help primary care providers to learn how to do this? I am a primary care provider, but I also work in our integrated primary care eating disorder clinic. And I did not learn this stuff in medical school. I didn't learn this stuff in residency. I learned this stuff when I was out in practice through Dr. Lebow, through my own interests that kind of drove that way. All we learn about is some simple screening tools and those made for TV movies and how to identify patients. So the reality is you have probably a 15-minute visit. Some of the primary care providers that I've talked to, some have 7 to 14-minute visits. At Mayo Clinic, we are so lucky. We get 30 minutes with our patients, which is in no way adequate amount of time to address this. When I have a patient that comes in with a new eating disorder and it's never listed as a new eating disorder, it's usually something that I look at their growth chart and my jaw drops and I know that there's something serious going on. And so I can delve into it deeper halfway through the visit. Those visits are going to be extended and I'm going to be running late because I know that this is really important. So what should you bring to your visit with your primary care provider? So you should go there with your child. You should not send them there alone. That's really, really important because anorexia, as you all know, is an egosyntonic disorder, and they are not going to willingly want to relay the information that is typically going on because that's part of the disease process, right? The disease wants to continue to be, possessing and your child's brain and their body and continue to cause them harm. So they're not going to typically willingly come in and say, I have an eating disorder. Yeah, it's happened before for me, but it's not the typical presentation. So if you're lucky enough to have a primary care provider who has access to your child's records from birth, great. But most people move around or they're seen in different locations. So if you can bring in a growth chart, if you are seen in multiple locations, bring that in because that is gold. To understand how a child grows is there's nothing more telling than that. A child should grow in a very predictable manner for both their height and their weight and their BMI. When there's big changes in any of those are huge red flags to me that there might be something else going on. Or if your child is just not gaining weight, also a huge concern, and I'll get into that more on the next page. If you can come in and explicitly state and say what the goal of the visit is, that's really helpful to us. I'm here today because I'm concerned about my child. I'm concerned that they might have an eating disorder and I want to talk to you about it today. Instead of waiting until the end of the visit, we call them the oh, by the way questions when we're walking out the door. If you can just tell us what your agenda is, we want to be there to meet that and help figure out what's going on. And then if you can bring some context about what's going on, what have you seen? What are the change in behaviors compared to previous? Because I might not realize that this is different when I'm hearing just from the child alone, but you might say, all of their favorite foods, they don't eat them anymore. Now they're only vegetarian and they cut out gluten and they don't eat sugar and stuff like that. And so I wouldn't necessarily know what's going on if I didn't have that context from previous or premorbid part of the disorder. If possible, when you're setting that agenda, you can say, I'd really love 3 minutes to speak to you alone. And then also being willing to step outside to allow that provider to have that one-on-one time to speak alone with them. Because sometimes your child will say things that they wouldn't say in front of them. And usually in my eating disorder clinic, I'll hear parts of that eating disorder come out during those opportunities as well. And then your provider in that visit, and they probably won't be able to get through everything in that first visit, but we need labs, we need a medical exam, and we typically need some type of EKG or imaging. And then saying to them, when's our next follow-up going to be is really, really important. We'll get into that more in slides coming up. Next slide, Dr. Lebow. So as in a realistic world, these are all the things that we'd want them to go through in their first visit. And in my eating disorder clinic, I get 60 minutes, which is never enough time. We usually find I take 90 minutes on every single one of my first consults. But when I have a patient who's lost a bunch of weight and they're not giving me anything in regards to symptoms for an eating disorder, I need to make sure there's nothing else going on, like celiac, inflammatory bowel disease, cancer, like diabetes. There's a whole bunch of things that can present with. So they will do some quick questions to make sure there's not something else going on. We call that review of systems. They'll go through their GI, endocrine, cardiac, and then if they're a female patient, getting their menstrual history can be really, really telling. Your body typically cannot stop menstruating if it's not able to sustain a pregnancy. And that's kind of the way I explain it to my patients. Like if your brain puts the hold on it and those signaling pathways, because it's in a state of malnutrition and it's trying to conserve everything it can. Reviewing that growth chart together. So one of the most important things, and I think gets missed all the time, is a higher BMI patients, they lose weight and everyone's cheering for them. Yay, yay, great job, right? That is the most damaging thing we can do to a patient who's developed anorexia or bulimia or some type of binge eating disorder when they're struggling with that. So recognize before we start praising them that it's being done in a way that's healthy and is not having some type of restriction or anything like that. A patient who, so high BMI, but then have come down to kind of maybe the normal range BMI, concerning. A patient who's lost rapid weight, that's the most concerning for medical instability. But the ones I think that get missed a lot, and the ones that go on for years, are the ones who are just not gaining weight and are losing percentiles. And that's the bottom growth chart there on the weight that you can see. And, you know, they're not super alarmed. People think they're going through the teenage years, they're going through a growth spurt, but that's really concerning for me because that happened during a long period of time. And that is going to ultimately potentially affect their adult height, because if we had like this patient to flip over to their length curve, you will have seen that their length percentiles have decreased as well. Then the provider can ask some specific questions related to eating disorder history. Some of my favorite questions are, how much time do you spend thinking about your body, your weight, or food? I love percentiles. It helps me put it in context of how consuming this disease is for them. I ask them if they've noticed a change, or some of the easiest things to get them to start talking about it, especially with anorexia, is like, are you doing anything to change your body or the way it looks or feels? And they'll be, oh yeah, I started exercising, and they'll start kind of giving me this stuff that then kind of gets my antennas up. I'm like, oh no, this doesn't sound healthy. This sounds like this could potentially be a disorder. Other things, which again, not really going to happen sometimes in that first visit. And so maybe your provider is going to get through it more in the second visit. They're going to get a good social and family history if they don't already know you. Hopefully it's somebody you do know that knows your family history and your social history. They will need to make sure that your child is safe, because as you all know, there is a huge comorbidity with depressive symptoms and anxiety symptoms in these patients, just to make sure this patient is safe. Most primary care providers get really distracted by the mental health presentations, because if you have a child who's having, you know, passive suicidal ideation, that's terrifying as a parent and as a provider, right? But you might be missing the underlying cause. And so we still need to kind of keep that in the forefront and just saying this weight loss happened first, you know, and bringing that up to them. Other things that is really, really helpful is this 24-hour dietary recall. I had it on the last slide. I have it on this slide. If you want to jot it down and just take before you come to the appointment and give it to your provider, super helpful, right? You can just pass it over to them. You don't even have to say anything. But the provider also, that's one of the really nice, easy ways that I work it into my patients when I'm one-on-one is just asking them what they've ate over the past 24 hours. I usually don't ask it in their parents' presence, because sometimes it's different reporting in their presence compared to when I have them one-on-one as well. So we can go to the next slide. So that's the history. And then we move on to the medical assessment. So the providers usually did not get orthostatic vital signs. So orthostatic vital signs are standing and lying, and they're over the course of a couple of minutes. And we're looking for big changes, drops in blood pressure, big changes in your heart rate, which would be orthostatic tachycardia. We're looking at these things. So if we have a patient who's lost weight, that's usually something I'm getting at the end of the visit, because I didn't know that I needed this before the visit unless I'm in my eating disorder clinic. They also need to get their temperature, because patients can have hypothermia with anorexia as their body is going into this malnutrition dormant state where they're trying to conserve every single resource available. Height that's accurate is very important, and then a weight with minimal clothing. Typically in their first visit, there's less of kind of like the extra clothing, layering, and weight or water loading and stuff like that. And then looking at their BMI curves. As they do kind of their physical exam, these are all the things that you can sometimes see present with eating disorders, but in reality, we don't see many of these physical things very often. If we do, that's very concerning. So in the cardiovascular area, they're listening to the heart. They will be getting EKG, which I'll be talking about in the next area. Edema would be a sign of heart failure or concerns with like your protein status in your body. With really low heart rates, you can be predisposed to arrhythmias, and that's one of the reasons why patients are hospitalized when they have profound bradycardia or changes in their EKG pattern. On their skin, looking for lanugo, we see this in anorexia or signs of hair loss from malnutrition. Jaundices can be a sign. Cholestasis can happen in patients who do have anorexia. So looking at their eyes, the whites of their eyes, under their tongue for signs of jaundice. For patients that have purging or bulimia, you may see calluses, which is known as the Russell sign on their knuckles from inducing vomiting. From the GI standpoint or from the history, there's usually a lot of GI complaints in patients that have eating disorders, specifically anorexia. So abdominal pain, abdominal fullness, bloating. They often have pretty significant constipation, and so we may see concerns for hemorrhoids or rectal prolapse from straining. Looking in their mouth is really important. If you're looking for dental erosions, that usually happens kind of a later sign with purging, or salivary gland enlargement, which also can be associated with purging and bulimia. From the history, we will see patients come in with extreme cognitive slowing, and just everything they say is slow because they're so malnourished and the disease process is so advanced. They'll have that cognitive rigidity where really struggling with anything that's not expected or transitions. That's going to elicit a pretty big emotional response. On their neurological exam, reflexes should be done. Reflexes will be changed. They can be hyper reflexive, meaning increased or decreased, based on some like magnesium and other types of electrolytes as well. And then obviously a depressed mood, just their affect, how they're looking, how they're engaging, are they making eye contact, kind of all of these sort of things that are comorbid with eating disorders, as we all know. You can go to the next slide. So I wanted to just take a minute to talk about the labs and the exam, because some of you may have medical background, some of you may not. And I know this is a busy slide. I put it all on there because sometimes I like to take screenshots and look at them later. Some families might want to just reflect on it. But high level, this is what that first evaluation should be done, looking for signs of medical instability. So CBC, which is a complete blood count, a comprehensive metabolic profile, which looks at electrolytes, liver enzymes, and protein, and then a couple other specific electrolytes and tests. And I'm going to go through them, a couple of them, but just kind of keep it high level. So if you're looking at your child's labs, like, what does it all mean? You see all these little red arrows and you're alarmed and you're concerned, like, does this mean we have to go to the hospital? Not always. There's certain ones that really catch our attention. So with profound malnutrition associated with anorexia, you will see your child's bone marrow be suppressed, and it stops producing as many white blood cells and platelets that are really important. So you will see low white blood cell counts, sometimes neutropenia, which is really concerning because it helps them fight bacterial infections. And then you'll see decreased hemoglobin or anemia secondary to the malnutrition as well. On the comprehensive metabolic profile, we call it a CMP. Things that I'm really looking for are like the electrolytes. So specifically potassium, because that's a bad one when it can cause big changes to the heart and causing an unstable cardiac endometrium, which can lead to arrhythmias in patients. You will see a low glucose level. Patients will sometimes be admitted for just hypoglycemia because their glucose levels are just low and not able to maintain them as their glycogen stores have been depleted. Glycogen is converted into glucose. So that's where our little fat comes from as well. Sometimes we'll see patients with kidney impairment, and they will have renal dysfunction that sometimes lasts months in these patients with their elevated creatinine levels due to this kind of chronic dehydration and malnutrition, or alternatively, also a really low creatinine level, and that speaks to the malnutrition and just poor muscle mass that these patients have when they're not in the typical expected range for muscle mass. Creatinine is a byproduct of muscle breakdown, and it's excreted in the kidneys. Calcium is usually low, and this is at the expense of bone health. Something happens called reabsorption, and meaning your bones steal the calcium and the phosphorus to maintain critical functions involved in your cells, because you need these two types of electrolytes. And that is totally at the expense of your bones and your bone health. You'll see your total serum calcium being low, but you will also see low bone density that we'll talk about on the other slide. The next one is pre-albumin. This is one of my favorite ones. You will see this decreased in malnutrition. And it's one that will start to improve after you start to improve their protein nutritional status. Magnesium can also be low, especially if we're having laxative use. But phosphorus is the big one. This is the one that you guys are probably all aware of. We worry about refeeding syndrome. It's probably not as common as we thought it was, but if you have a patient who's starting with a low phosphorus and you haven't even started the refeeding process, you're going to be needing to watch that closely to make sure admission isn't needed or oral supplementation isn't needed. The next thing would be on thyroid function. Ferritin is a marker of your iron stores. And so high level things that you would need to take, that I would recommend taking away from this is vitamin D and ferritin are low in almost every one of these patients and need to be replenished. Vitamin D, if you're giving high levels of that, needs to be given with calcium, or you're not going to be able to absorb it. So these patients also need calcium supplementation with their vitamin D. You can go to the next slide. I already talked about the EKG. And this is some additional workup. This is if we're still trying to make sure that there's not something else that is going on or a comorbid presentation. So ESR and CRP are inflammatory markers. They will be elevated if there's some type of chronic inflammation going on in your body. They don't tell us what it is, but they say, hey, you need to look further. Celiac, we've seen patients present in our clinic with new diagnosis of celiac disease and anorexia. That's the whole backing yourself into an eating disorder thing. Sometimes other GI studies like looking for pancreatitis or chronic diarrhea may be helpful. Very rarely do you order other vitamin deficiencies unless you have some type of concerns for a malabsorptive process. And then amenorrhea, which is lack of menstrual cycles for 3 months or more, depending on how far they are from menarche. Sometimes we allow a little bit longer. Those, we know that patients who have anorexia, there's actually high levels of polycystic ovarian syndrome, or patients with PCOS are at higher risk of developing eating disorders. And so you can be normal weight and have polycystic ovary syndrome. And that's another huge myth that is about 1/3 of patients with PCOS are normal weight and not overweight, which has been typically taught to medical providers. And then bone mineral density studies and sometimes other imaging. Typically, you need a bone mineral density study if the eating disorder has been going on for at least 9 to 12 months, or if they have at least 6 months of no menstrual cycles, you should be getting a baseline. But really the treatment for low bone density is nutrition and weight restoration. Nothing else has been shown to be anywhere near as effective, including the medications. You can go to the next slide. So when do you hospitalize? These are all resources that you can share with your primary care provider from the American Academy of Pediatrics. They have a whole practice statement on this. The AED Association, they all have the same criteria for hospitalization, which is very helpful. We look for signs of dehydration, electrolyte deficiencies, and changes in their vital signs. EKG changes are usually the ones that are going to get them most likely admitted. Sometimes they will admit a patient based on their BMI alone, but usually in most cases, especially with the huge need for inpatient treatment across the United States, there might need to be more, and they would usually, in our case, tell us to continue outpatient treatment. Behavioral, if they're having acute food refusal for more than 3 days, is sometimes a criteria, but it's hard to keep them admitted if there's not something else going on, because as soon as they eat, the insurance companies say you have to discharge them. And then if you have concerns for their safety with like suicidality or otherwise unsafe thoughts, those would be the other reasons to consider admission. Next page. So reality is your child is going to be okay. They most likely don't have any of these admission criteria, but then you call all the eating disorder centers and you got a 6-month wait and you're terrified. You don't know what you're going to do. You've read your child can die from eating disorders. And so how are you going to bridge? And so this is really, really important. I did not know about this until I started getting into this. So if me as an eating disorder doctor didn't know about this, I'm guessing most primary care doctors do not know how to do this. And I've seen my partners be like, oh yeah, I'll bring her back in 2 months. No, they cannot wait that long. They need to come back every week or every other week. Every 2 weeks sometimes is not enough to be the support that you need as a parent, and the voice that your child needs to hear in regards to the seriousness of this, how they need to eat and so forth. So every 1 to 2 weeks, your provider should be monitoring weight. They should be doing full vital signs like the ones I talked about before, and labs if your child continues to lose weight, and they should be getting labs at every visit if the child is losing weight. And the reason why is we're looking for any reason that we would need to admit them. It also helps sometimes that patient to understand that this is serious. We mean serious business if we're going to be getting labs this much. We're scared for you, and this is why we're doing this sort of treatment. But again, it's really hard to rationalize with a patient who has a disease and getting them to understand it. So if their weight is up, great. High five to the parents, you're rocking it. What do you need for support? And the message that I give is 3 meals, 3 snacks. Try and supervise everything that you can. We'll teach you everything else you need to do when we start FBT. But I need you to at least maintain your child's weight and stabilize the weight loss, or even gaining weight. That would be great. If the weight is down, then they need to consider EKG again, electrolytes with that CMP plus Mag and F.E.A.S.T, and then orthostatic vital signs, and then they need to bring them back every week in that case. So the last slide is, what are the signs that maybe like this relationship isn't going to work? I would say, 99% of primary care providers are going to do a really good job. They just don't know what to do. There's not a lot of resources out there. There's no training, and we don't have a lot of time. So bridging, being partners, being allies, working together is the best case scenario. But if you're getting a bunch of red flags that this could actually be detrimental to continue to work with this provider, then get a new one. That's okay. You are in charge of it. You are the person who's advocating for your child. So ask for what you need. So a couple of like red signs or red flags that we've seen, and I'm sure you have all heard of as well. So the provider is really obsessed with healthy weight, and it's the only thing they care about. And they're like, oh, but your child's in a healthy weight now. They're not obese, and they're like using language like that, and suggest like, oh, your child should just keep doing what they're doing. They're healthy now. Another thing would be just only focusing on the mental health aspect, and they're not recognizing the eating disorder, even though you've like spelled it out for them forwards and backwards, and you keep trying to bring it up, and they're just not validating your concerns, or even looking into them anymore. Like, it's okay, escalate to somebody else, get your child the care they need when they need it. And then this is the best case scenario. These are my partners that I work with sometimes. They're like, I don't know how to do this, but Dr. Mattke does, or Dr. Pardine does, and I'm going to get you in to see them, and I'm going to talk to them. Would you like me to transfer you to somebody else to be seen? And you're like, yes, thank you so much. So those are people that are recognizing, their limitations and getting you the care that you need and meeting you where you're at.
Great. And so, at the end of this is a lot. What we've done here is kind of pulled together. And again, you guys are probably familiar with a lot of these resources, but these are things that if you have one of those primary care providers who is well-intended, but just doesn't know, I think these are good starter sort of resources, right? There's the AAD Purple Book, which has all those guidelines for medical management, for hospitalization. There are the Golden and the Rosen articles are really good overviews. They're from the American Academy of Pediatrics, from the Society of Adolescent Health and Medicine of what we need you to do. If you're in FBT, Katzman and company wrote a really nice guide of what FBT looks like for a pediatric provider who doesn't know. And then if you have to, these are like revenge papers. That's what we call them in my practice. When you have a provider who's just really stuck with like, I really want to put her on an SSRI, I think that'll help, or I really think he needs an antipsychotic. These are kind of the literature that we have that says things like, you can put someone on an oral contraceptive and their period can come back, but that doesn't help with bone density. Or people with high BMIs can have restrictive eating disorders. People, so again, sometimes, not often, hopefully, but if you need a little bit of scientific backup, these are some of the ones that I have pulled out myself. We want to thank our team at Mayo, as well as just in the greater eating disorder community. We're really grateful for our collaboration. And I think we'll end there for questions.
Thank you. You covered so much ground in such a short amount of time. So really, thank you. Anybody have any questions? I do, but I'm going to let other people go first. So just raise your Zoom hand and ask away, or I'll start. So first of all, I want to say that this was the first time that anyone actually validated something that I experienced with my primary care physician, which was when you talked about distracted by mood. I thought that was just us. And, when you wrote that, it kind of just, I was like, wow, it was not just me. So that was like, super helpful for me to at least, know that it was not just me. And I do see that we have one question. So let me just ask mine, and then I will guess the question that we have. I, you gave that whole list of resources at the end, which is amazing. Should parents try to educate primary care physicians? Meaning, you talked, Dr. Mattke, you wrote, in your slide, you said, find another, physician if yours isn't, validating your concerns, if yours isn't listening to you. But, I guess the general question is, are we just going to be patronized? Is there any point in presenting these, papers and literature?
I think so. This is tricky too, because I think it depends. It depends on your provider. It depends on how they approach it, right? There are providers who truly just don't know. And then it's like, I think I've read this. Would you mind? Would you be willing for me to bring this, right? There are providers who don't know, don't care, right? And that's a different type of thing. I think you have to feel it out. I do also think you have to keep in mind that idea of how busy they are, how these are well-intended people. And so if you march in with a binder and be like, I need you to read these before our appointment, like, that's not going to probably be the most effective. This is like a psychology thing. You can be right without being effective, right? And so it's kind of balancing it out. How do you deliver it? But if you can't at some point get to the point where you're having an open conversation about this with your provider, then I think it is time to change, right? If they're just so resistant, if they're just so stuck on it, they have to be right. I think that you have to change. And as to the mood thing, and then we'll, I think that is something that, I'm a psychologist, and I really think psychologists and psychiatrists, we're a little broken in terms of the amount of depression we're comfortable with. Primary care providers are not. This has been a learning curve, because you guys know, when patients have eating disorders, they are distressed. They look flat. They are they're self-harming. They don't want to live. It is scary and terrifying. Mm-hmm. And so, on one hand, it's understandable that primary care providers get distracted, but you're right. In doing so, they can miss the boat sometimes. So I think that that's just important to keep in mind.
Yeah, and I think most of us want to partner, but there are some people out there who maybe have personality disorders that aren't as receptive to hearing things. But I have learned so much from my patients, not about eating disorders. I have had parents send me articles all the time. I found this lump. Here's an article. I think this is what it is. I'm like, that's really cool. Let me get you to the specialist. Thanks for sharing. You know what I mean? So, don't overwhelm them with resources, but just be like, hey, I was reading this, or I learned from F.E.A.S.T. F.E.A.S.T. has stuff on their about some of these things on their website as well. So I think there's a way to come at it, as we want to be partners instead of adversaries. And I try to always assume a benign intent, and sometimes I come at it and I get hot. So I just kind of keep that in your mind too, if other people are like that. And then I just saw a message on there from Dr. Peely. I would say, yeah, you could offer that to your primary care provider as well. So Mayo Clinic Talks is a free CME online podcast that anybody can listen to. It's geared towards providers in primary care or general practitioner settings. As a primary care provider, you can listen to and get CME credits for it, and they're very inexpensive because we all have to keep up our CME. But we did seven episodes for primary care providers of how to address eating disorders, and they're super easy to listen to, I think, and they're fun, and they provide a ton of information for primary care providers, because we basically taught you everything we didn't know when we started.
Thanks, and that's thanks to Dr. Pelly. Mayo Somewhere the Mayo Clinic Talks person is like, oh, why wasn't that on your slide? So thank you for bringing yeah, that's another good resource.
Okay.
Sorry, Mara.
Just turned 18. She's only been at this less than a year.
Yeah. Yeah. So this is getting my blood pressure up, because this is, I think, a fight that we all have had, yeah, I again, speaking obviously generally, I don't know your daughter, I don't know the treatment, I don't know all these things, but underweight restoration, I personally believe that it's one of the reasons there's such a high relapse rate in anorexia, because these cases that we say are recovered, I don't think we ever even got them there. This idea of harm reduction, you're right, that's something that we do for the chronic patient, where we're just trying to keep them out of acute medical risk. I think your concerns, I want to validate them. I think especially when you're seeing behaviors like manipulation of weight, that to me, it doesn't matter what the number on the scale is. That's somebody who's not, who's still quite ill. Again, I can't, obviously I'm not commenting on your specific child, but I think that is a time, and it's difficult because she's 18, your daughter's 18, you've got a whole treatment team, and it's very hard to get treatment, but it sounds like it's a mismatch between what feeling heard, right, and feeling like it's the right treatment for you. At the end of the day, and this happens with many patients that I see as a psychologist, right, what we do has to make sense for you guys as parents and guardians, as the people who love these kids the most. If what we're doing, if you're not seeing it work, if it doesn't make sense to you, you have to make a call to do what's right for your kid, what you think is best for your kid. And sometimes that means changing treatment. Sometimes that means having a case conference with everybody at the table. Again, it sounds like you've tried to do it, but it shouldn't be, especially when it's your treatment team. I just want to be clear. Every family we see is in distress. Every family we see is not communicating at their best because they're scared for their child's life. And so I just want to be clear that it's not, I don't want you to feel like I didn't say it the right way, because that shouldn't be a criteria with your treatment team.
Thank you. Yeah, I keep, wondering that and trying to, trying it multiple ways, in writing, in person, group meetings, and it takes a week to get a group meeting. And meanwhile, it's like, and I understand it's really hard and everyone's busy, but it's just been a real, and now I'm fighting. I feel like the eating disorder has been given a huge boost and ally in and around weight restoration. And I'm like, so I have to make very difficult or present difficult options to my daughter, which are not comfortable as a parent. So,
Yeah.
But I appreciate that feedback very much. Thank you.
Oh, thank you. Really, thank you, Drs. Lebow and Mattke, so much for being with us today. We really appreciate it. Our next webinar is on June 1st. Dr. Richard Kripke is going to talk about what I've learned from patients and parents. I think it's going to be super inspirational. So please join us on June 1st if you can. And thank you again. It was great seeing you all, and we'll see you next month. Bye.